evening, everyone. The purpose of today's class is to familiarize you with some of the interventional angiograms. We will start with those that you're very familiar with, you won't have any problem. That is to introduce you to what I am going to show. As you go along, you will find that the angiograms are becoming a little less familiar, but we should be able to read them and identify the intervention and answer the questions that come. The first one, Akshita, you have already seen. Just tell me what is the procedure and when do we do this. You can send it to me as chat. Yes, you're correct. It is balloon septostomy. Tell me the common indications. I wouldn't wait for that. You know that it's normally or most commonly done for TGA intact septum. You could also use it in any other situation where there is a restrictive interatrial communication and you want a adequate interatrial communication. The situation could arise in tricuspid atresia, anomalous total veins, or mitral atresia. So something very simple. Now look at this angio. You need to describe the findings. Yes, actually I am moving on from there. I included mitral atresia as representative of hypoplastic left heart syndrome, so your answer is correct only. Now in the angio that is going to come, you should describe the findings. You should tell me what the procedure is, and then I will ask the questions 3 and 4. These are 3 clips which have been joined together to make one movie. Please tell me first whether this is clear for you. Okay, good. So there are 3 components to the movie that you are seeing. The first is pre-procedure. The second, you can obviously see a balloon. And the third is post-procedure. Tell me what is it that you are seeing. Yes, it's balloon pulmonary valvulotomy, etc. And you didn't tell me what was the first angiogram. I said there are 3 components to it. So this is the first thing that you are seeing. So yes, it is RV angio in lateral view, which shows a thick doming pulmonary valve, and therefore it is severe valve PS. So your reading of the angio should be that an RV angiogram in the lateral view, which shows a thick doming pulmonary valve, and therefore it is severe valve PS. And this is the jet, and this shows the narrow jet across the doming pulmonary valve, the post-stenotic dilatation of the pulmonary artery. So you are dealing with severe valve PS. And then your next image is the balloon across it. So that is obviously the procedure. And following the procedure, what you have seen is the RV angio again in lateral view, which shows that the valve is now open and the jet is broad. So that is balloon pulmonary valvulotomy. The 2 other questions which I had asked, already the answers have been shown, is when is it on an echo image or an echo Doppler, you would make a decision to go ahead with the balloon pulmonary valvulotomy. You should have a gradient of at least 64 millimeters of mercury. Remember, your 40 millimeter gradient is a transcatheter gradient. And as you would be taking the decision based on echo, it's a Doppler gradient that you take which overestimates the actual gradient. So you look for a gradient of 64 and you choose a balloon annulus ratio of 1.2 to 1.25. Okay, I hope you were able to see this well. I'm moving to the third one. Here again, you must describe the findings. Indication for the procedure in a neonate. How do you choose the balloon size in this procedure and how do you define the outcome? See this angiogram. The procedure is obviously in the neonate. So tell me what is the procedure? How do you evaluate that procedure? It is balloon aortic valvulotomy. Yes. Once again, when you are describing the angiogram, remember it's an aortic root angiogram which shows a doming aortic valve, and the next image shows the balloon across it. And the other question was, yes, retrograde aortic root angio. Try to say it completely. And you are looking for the indication is for a mean transvalvular gradient of 50 millimeters of mercury in the absence of LV dysfunction. In presence of LV dysfunction, any gradient with LV dysfunction would be an indication for balloon valvulotomy. You do the balloon aortic valvulotomy for a mean gradient of 50, and if there is LV dysfunction, a much lower gradient would also be fine. And your balloon annulus ratio is just less than 1, 0.8 to 1. And in a neonate, a 50% decrease in transvalvular gradient should be acceptable. That should be considered a good outcome, because if you try for more, you end up having severe aortic regurgitation. Okay? And moving to the next one. This is the fourth angiogram. Please tell me, what does the angiogram show? What is the procedure? I haven't got an answer yet. When do you balloon dilate a PDA? Yes, Sujata, it is PDA stenting. Very good. So it's an aortic root angiogram showing a PDA, and for some reason, somebody has decided to stent it. So you can actually see this. It may not be that clear in transmission, but when you find a balloon and when you find a wire in the pulmonary artery across the PDA, obviously you are stenting the PDA. So don't tell me you are balloon dilating the PDA. Okay? So that is an aortic arch angiogram showing PDA, and the PDA stent being deployed is what you said. And the common indication is either a duct-dependent pulmonary circulation, most often, or a duct-dependent systemic circulation as part of a hybrid procedure in hypoplastic left heart. Most common for providing pulmonary artery blood flow in a tetralogy pulmonary atresia, single ventricle pulmonary atresia, in some TBAs when you want the ductus kept open. So those would be the common indications. As a hybrid procedure, you could do it also in a hypoplastic left heart. Okay, so that was a PDA stenting of a normally located duct, and the approach was from the aorta, from the femoral artery. Now, see this angiogram and tell me what is the procedure and what is the access used and what are the advantages of this access. The image itself doesn't move. What you see is the catheter, the balloon and the wire. Tell me what is it that you are seeing. Again, as the frame indicates, it's in the newborn. Left axillary, yes, Akshara. Left axillary, what are we doing? PDA stent, yes. So it is in a PDA stent from the left axillary artery approach. When is it that this is preferred? What is the advantage of choosing this axis? Vertical PDA, excellent Akshara. That's the complete answer. So what you saw was PDA stenting through a left axillary artery approach is particularly useful for a vertical PDA from the undersurface of the arch. Okay? Angio 6. Now once again you need to tell me the axis, the angiograms, and diagnose the problem. Tell me the setting and the procedure, and when do you do that? Take your time, describe this angiogram, and tell me what is it that you are seeing. Hello? If you're unable to make out, please tell me, because we need to move on. I need a response from you. No. Branch PA, no. Any other response? If not, I'll go to the this is an Angio 6A. Oh, Riyanka, you got it. And I was about to tell you, see the next angiogram, and then you will get the answer. Riyanka is spot on. So what is it that we saw? In the first angiogram, there is a direct injection into the main pulmonary artery. The surgeon has provided the access. It is obvious that it's a surgical field. You can see the sternum being held open by the retractors, and the surgeon has given the access into the pulmonary artery. So there is a catheter or a sheath which is going directly into the pulmonary artery. And when you are injecting that, what you are finding is a huge PDA which is continuing as the descending. We were seeing, and I hope all of you have made out the situation by now. I was saying that we have a surgical field, sternotomy, sternum being held open by the retractors. The surgeon has provided access to the main pulmonary artery, and the injection shows a ductus continuing as the main pulmonary artery. I'm sorry, the ductus continuing as the descending aorta. There is pulmonary artery branch banding. This is the background for a hybrid PA stenting, and that is what Angio 6B shows. You find a large stent, this is 8 mm in this case, which is flowing well, through which dye is flowing well into the descending aorta. And you can also find that there is enough retrograde filling of the arch and the ascending aorta, which the ductus needs to fill in a case of hypoplastic left heart. So what you saw was the PA angiogram showing the MPA, large PDA and descending aorta with a banded PA branches. That band you may not have been able to identify. So this is hybrid stenting, and this is an alternative, as you know, to Norwood stage 1 in hypoplastic left heart. We move to the next one. This is a combination of angiograms again. Look at the clinical scenario. It's a 5-year-old boy. His weight is 10 kilograms. He has a fair effort tolerance. His saturations are 96% in the upper limb, 80% in the lower limb. His lower limb pulses are slightly weak. Get that scenario in your mind? Now you will have to describe the angiograms and reach a diagnosis. And then I will show you a procedure which was done on him, and I would ask you what the outcome is. Okay, ready? Here we go. This again is a combination of two angiograms. One is an aortic root angiogram, the other is a main pulmonary artery angiogram. In your mind, try to separate them and see what does the aortogram show, what does the PA angiogram shows. If you want me to play again, if it stops, you should tell me. If you have any question to ask, any further clarification on the clinical setting, you can ask me. It's not something that you would very commonly see. There is an aortogram, TGA, PDA, coarctation. TGA, you are presuming, what is your evidence to say that there is a TGA? It's not TGA. I'll play that again. Actually, there, reverse differential stenosis could mean TGA, but it doesn't always. You should take it in the context. So, see the angiogram and see what is it that you're seeing. Forget the TGA part of it. You are too much influenced by multiple choice questions. I want you to describe the aortogram. Don't tell me anything else. Just describe that aortogram. Anybody? Try not to see the PA injection now. Describe the aortogram. In fact, I can try to freeze it for you. There you go. You have mainly the aortogram on the screen. 5-year-old child, 10 kg weight, differential stenosis. Yes, this could be interrupted aortic arch. Good. But is there something more than that? Once again, you are guessing from the clinical scenario. It's good, but also see the angiogram. There's something more than interruption here. Okay. I'll wait for 10 seconds. Here we go. This aorta, look at this ascending aorta, it's obviously narrowed. No, there's a severe supravalvular stenosis of the ascending aorta, or you can say that the ascending aorta is severely hypoplastic. Then it opens up, and then the arch again becomes narrow and opens into it and leads to a severe coarctation. Just watch the aortogram. Don't look at the PA angiogram. You find that the proximal aorta is quite hypoplastic. It looks all chewed up, and the proximal aorta is very small, then the arch is hypoplastic, and then there is severe coarctation. If this is the situation, something has to provide blood supply to the lower limbs. After all, the child is alive at 5 years. If this situation was present in a newborn, the child would die. Here, nature has done something for the child which is allowing him to survive. Look at this. Look at the ascending aorta narrowing. Look at the arch hypoplasia. Okay, that's all that I have shown now. Now see, as we go further, the descending aorta is filled by the ductus, which is aneurysmal. That aneurysm you can see in the under the arch. My marker is on the ductal aneurysm. Got it? So you have a ascending aorta which is hypoplastic along with coarctation and arch hypoplasia, with lower limb being perfused by the descending aorta. The ductus. Now, somebody called this reversed differential cyanosis. This is standard differential cyanosis. No, it is the lower limb which is desaturating. So it is a standard differential cyanosis, which means that the venous blood is perfusing the lower limb. And that is shown by the pulmonary artery angiogram. Now, if you see only the pulmonary artery angiogram, you will realize that it is a PA which is continuous as the here. I am moving this slowly for you. What are we seeing? It is an injection into the main pulmonary artery, and you are seeing the main pulmonary artery directly continuing as a descending aorta, which is what you will find in interruption or in severe coarctation. In this case, there's one more thing. With such an anatomy, you would expect the pulmonary arteries to be big, but the pulmonary arteries have a branch stenosis or a bifurcation stenosis. So this is nature's hybrid stage 1 Norwood. What has nature done? Nature has given stenosis of both the origins of the pulmonary artery. Nature has kept the duct patent. So you didn't need to do a ductal stenting for this child. Do you get me? Here is a child with severe hypoplasia of the ascending aorta followed by coarctation and lower limb blood supply maintained by a ductus. You don't want that ductal flow to go into the pulmonary artery. So nature banded the pulmonary arteries too. So a very Norwood stage 1 hybrid-like situation provided by nature. Now what can you do for this patient? That was the big question. So look at the next angio. So can you describe what is it that's happening here? Now that you have a clue as to what was the anatomy. Tell me this procedure and its outcome. I hope you can see the image. This part you should be able to say. I need a response because otherwise you need to explain and move on. Please. Again, I'm giving the 10-second deadline for me to tell you what it is. Okay, no response. The 10 seconds is over. The first part of the answer in the slide describes what we saw. Sujata, it's not enough to say coarctation stenting. This is arch stenting. So the procedure done is arch stenting. What the angiogram had shown was the severely hypoplastic ascending aorta with distal transverse arch hypoplasia and post-subclavian coarctation. So say hypoplastic ascending aorta with coarctation. And descending aorta was being filled by the pulmonary artery and the ductus with the branch stenosis of the pulmonary arteries. We have stented the arch. There is actually a Cook formula stent in the arch. There is a residual waste, but some increase in the flow to the descending aorta was achieved. It is still not well filled from the arch because the ascending aorta is still hypoplastic. But the procedure attempted was arch stenting. Why the arch stenting was done here? You cannot send this patient to surgery directly anyway, because without the ascending aorta growing, or unless you are able to patch the ascending aorta, and if the LV is adequate, then only something you can do for the child. If you can relieve the coarctation, it is possible that the ascending aorta might grow. So we stented the arch we relieve the coarctation, at least substantially, if not completely. In the short run, the patient did well. Do you want to ask any questions regarding this? I'll again give you 10 seconds. Otherwise, I'm moving to a different angiogram. So this was not something that you would ordinarily see, but rarely we come across these situations where what we wanted to do, nature has done, and we find it very difficult to better it, and we are in a dilemma as to what should be the long-term management. 10 seconds. So no forward flow in ascending aorta. So how does it grow? By stenting. Look, you haven't seen an LV. You haven't seen an LV angiogram to say that there is no forward flow in ascending aorta. You have only seen the hypoplastic part and this, no? So stenting the arch and relieving the obstruction is some form of palliation. If it improves, well and good. Otherwise, you haven't done any harm. As I said, in the long run, this child's aorta didn't grow. But our idea was to maintain the well-being of the child, relative well-being, for a longer time. I moved on. This is a different angiogram and a different intervention. So describe the angiogram and diagnose the condition. You must see angio 8A first and then B, or either way. There are two angiograms and there is an intervention being performed. You must give me a diagnosis, tell me what is the intervention, and tell me what's the outcome of the intervention. Anybody getting any clue? Very good, Sujata. It is Scimitar syndrome. Can you tell me why did you say it is Scimitar syndrome? Tell me why you said it is Scimitar syndrome, and then tell me what the intervention is. I'm very impressed that you called it Scimitar right away. Very good. Yes, Akshita, there is a dextrose heart. What does the angio 8A show? The intervention is certain expressions you tend to use automatically. Do you see a coil there? Yes, Bhargavi, what you see in the angio 8A is the Scimitar vein. So from the IVC, you have entered the right lower lobe pulmonary vein, which is draining into the IVC. So the first angiogram shows that the Scimitar vein is draining into the IVC. Now let's concentrate on 8B. My objection was to somebody who saying coil closure. I'm sure you can see what is it there in that artery. It's anything but a coil. Yes, you're calling it a vascular plug, I don't mind. It's actually an ADO2. But when it is stretched out, if it looks like a vascular plug, I have no objection. But you shouldn't call it a coil. So you can, if you wanted an expression, call it a catheter closure of the collateral, and then describe the device. After all, when this type of an angiogram is shown to you in an exam, certain things are expected. So your answer should be complete. So your angio 8A therefore showed the right lower lobe pulmonary vein angio, which has been reached through the inferior vena cava. The vein drains into the IVC-RA junction in a dextrose heart, and there is aberrant arterial supply to the right lower lobe from the lower descending aorta. So this combination gives you the diagnosis Scimitar. And the collateral artery has been embolized with an ADO2 device, and there is no pulmonary venous return in the levo phase. So the collateral has been completely closed and its pulmonary venous contribution cut off. Any question relating to that? 10 seconds. Any question related to that? If you're asking immediately, I will answer that. Otherwise, I'll move on. No questions? You're happy with it? Okay, very good. Next. This is a 20-day-old baby who was found to be severe pulmonary hypertension and was on a ventilator. He underwent one procedure on day 20, which did not improve the clinical condition. So he underwent a recap and another procedure on day 40. So what you see now are the angiograms related to the day 40 procedures. I want you to describe the angiograms and reach a diagnosis. You must also tell me what are the procedures done and what are the devices used. So, 40-day-old baby who had a procedure at 20 days has severe pulmonary hypertension on ventilator. Here we go. Look at 9A first. I would say don't look at 9B, just keep looking at 9A, then you will get the diagnosis faster. I'll come back to 9B. What is it? What is the angiogram in 9A? What is your finding? And what is being done? Not a very common situation in a newborn. More often you would have seen the same procedure being done in an older child or maybe even in an adult. But this was a newborn. Angio 9A. Don't look at 9B. Look at 9A. Bhargavi, yes, pulmonary arteriovenous malformation. Excellent. Parvesh, pulmonary AV fistula. Okay, both are more or less same. Akshada is more specific. It's a right pulmonary artery, pulmonary AV malformation. Okay, all of you are right. So what you are seeing, the injection is into the right lower lobe of the pulmonary artery. Right lower lobe pulmonary artery, there is an injection. And that shows this tortuous vessel. I can probably, yeah. Now I've stopped the angio at that point so that you can see that vessel. Can you see this? This is the pulmonary artery. It is feeding this tortuous vessel which is going somewhere. Where it is draining, it's difficult for you to find out, so I will not ask you at this point. So that is what the image shows. This neonate's pulmonary hypertension was because of this huge pulmonary arteriovenous fistula in this child. And the treatment for that is also seen in same angio 9A. Now keep looking. Something is exiting from this catheter. Can you see that? Something is exiting from this catheter. There's already a device somewhere here. This is a device somewhere here. Now, see this angiogram once again. So in this, with a device already in the background, another device is being introduced here. And what happened after the device, this film will show. Now look at 9B. Don't look at 9A. Look at 9B. Do you see the fistula now? Fistula is gone. So we have succeeded in closing that fistula. Again, what is closing the fistula is an ADO2 device. You find another ADO2 device deep within that lung. Closure of PAVM through feeding artery using ADO2. Now there is a twist in the tail. That twist in the tail is that this patient also had a Scimitar syndrome, which is the first angio that I showed you. So we did the first intervention on day 20. So when this baby came with pulmonary hypertension and when the baby required ventilatory support, we thought that Scimitar with the large collateral blood flow explained for it, and the collateral flow was occluded. At that point, we had not done a pulmonary artery angiogram and we missed the AVM. As the baby stayed on ventilator, we took the baby up for another study and then we found that there was this AVM, and closure of this AVM that settled the problem. The PA pressures on the table dropped to half system. The first Scimitar angio that I showed belonged to this patient only. And the device that you find here is the device that we had put in the Scimitar collateral artery originally. So read this answer. You were finding a right lower lobe pulmonary artery angiogram showing the tortuous fistula, which is actually draining into the pulmonary vein coming into IVC-RA. I did not ask that question because that is not very clear on transmission. But that it is a pulmonary AV fistula, you should be able to say. It's a dextroposed heart, and another radio to a device that closed the collateral artery to the right lower lobe is seen. So this is Scimitar syndrome. So we have this strange combination of a pulmonary AVM draining into a Scimitar vein. And we have the ADO2 devices closing the systemic collateral artery and the pulmonary AVM. This is an unusual problem, but two aspects of this you should be able to recognize. One, if you see a Scimitar, you should be able to call it a Scimitar. And in the first angiogram, the previous angio 8, it was clearly a Scimitar. So there is a pulmonary vein angiogram showing the Scimitar vein. There is a collateral artery embolization. So there should be no problem in that. In the second one, a pulmonary AV malformation you should be able to diagnose. You are injecting into the pulmonary artery. You are seeing a tortuous fistula and you are seeing a vein draining somewhere. So there you should be able to say that it is a pulmonary artery venous malformation. The connection is the interesting twist in the tail, which doesn't matter to you. I only disclosed it as part of the whole story. Like some time ago, I have presented this in CSI Frankfurt. Okay, any questions relating to this? Otherwise, I'll be moving on. Any questions relating to if fistula is draining into Scimitar by closing? Oh, I didn't get that answer. Sorry, I didn't get your response. It went away. Akshara, can you send that once again? If fistula is draining into Scimitar, by closing Scimitar distally, it should improve. I didn't get you. Did you mean that closing the Scimitar vein distally, it should improve? Oh, there is no problem. Perhaps that is another way of dealing with it. But the point is, when if you try to access it through one exit point, it might open up somewhere else. These fistulas are nasty fellows. When one exit, if you try to close, they have a habit of opening through somewhere else. So whenever it is possible to close a feeding artery, that would be our primary treatment mode. Okay? But good question. So I'm moving on to the next one. So this is a different angiogram, no more fistulas. You describe the angiogram, tell me what is the procedure, and tell me how would you assess the response to the intervention. Look at it carefully. It's nothing as exciting as the previous one. This is an older patient, this is a 7 or 8-year-old boy who has these angiograms. So tell me, what do you see in the first angiogram and what is the intervention in the second angiogram? Yes, Bhargavi, is a Fontan angiogram. Excellent. But beyond that, tell me that, describe that Fontan angiogram. Yes, Parvesh, I'm very happy that you are calling it Fontan, but there is a finding in that, no? What is a little unusual for this Fontan? So in the Fontan angiogram, okay, I'll leave it at that. In the Fontan angiogram, what do you find in the IVC and the conduit? You're finding a conduit stenosis, you can see here. And this patient had presented with protein-losing enteropathy. It's important to know that to appreciate the second angiogram. Now see the second angiogram. Good. So, Bhargavi, you have described the first angiogram first. Now move to 10B. Yes, we are sending the conduit. When there is a conduit or IVC stenosis following Fontan, that is one of the reasons for a protein-losing enteropathy, because the PA pressures tend to go up, and we are sending the conduit to relieve the obstruction. Okay, so this is a post-Fontan extracardiac angiogram showing well-functioning Glenn and with some stenosis of the IVC conduit junction. There is no fenestration that you can see. You don't see any venous collaterals. These are the things that you look for in a Fontan angiogram. And you extended the IVC extracardiac conduit, which is normally done in presence of a conduit stenosis for a drop in Fontan pressures. And the outcome that you look for is a drop in the Fontan pressures and a clinical improvement of PLE. Okay? Any questions here? And moving on to the next one. Okay, here we go. Angio 11. From the newborn to a 70-year-old lady with atrial fibrillation and congestive heart failure. Describe the angio and give the diagnosis, and then tell me what's the intervention. It's all in one film. 70-year-old lady in atrial fibrillation and cardiac failure. Aortic root angio. Tell me what is CCF? Coronary arteriovenous fistula from the left main coronary artery. Okay, actually I meant coronary cameral fistula. Remember, CCF will also be called congestive cardiac failure, which this lady is in. You're right. Your only problem is partly because the image is perhaps not as clearly visible to you as I would like. It's a fistula from the left sinus to the right atrium or to the high right atrium SPCRI junction. You can actually see the left coronary artery distinctly from there, and this is a left sinus to RA fistula. You know for sure that this is coming from the left sinus, but you do not know whether it is coming from the left coronary artery or from the left sinus. And take it from me, this type of a fistula more often comes from the left sinus rather than from the left main coronary artery. So this is a huge fistula from the left sinus going behind the aorta and draining into the SPCRA junction. Now if you see something that is popping into the fistula, can you see this? Where my marker is? There's something there. That is the treatment that is being done. What is it? Well, you believe that I will only use ADO 2. For a change, not only that this was ADO 1, this was a custom-built 2018 ADO 1 device. It's a huge fistula. So ADO 2, the problem, is limited by its size. 5.5 millimeter VSD is what you would close with it. So a huge fistula like this, you cannot close with an ADO 2. You need a huge device. So we had Cocoon give us a 2018 device to close this. It was closed through an arteriovenous loop, and what you're seeing is from the venous end, the Cocoon ductus device being deployed. Okay? Any questions here? Otherwise, I'm moving on. This is not an uncommon situation. Coronary artery fistula at any age you would see, from the infant to the very old. This lady had a dramatic improvement with the fistula closure. Okay, so this was you can read the answer. This is an aortic root angio showing the large fistula from the left sinus to RA. It's closed from the venous side by a PDA device. Okay. Now, angio 12. Describe the angiograms and tell me what is the intervention. Maybe angio 12B will help you to interpret angio 12A also. Should be able to tell me what is 12A and then tell me what is 12B. Come on, I'm sure that you can answer this. The first one is MPA stenosis with a Bhargavi, posterior case lateral injection branch PA showing PR. Okay. There's one more thing. Is this how the normal RV outflow looks? Why is the RV outflow that long? Conduit, yes, Akshata. This is a stenotic conduit with a stented branch pulmonary artery. And the injection shows severe pulmonary regurgitation also. Your injection is deep into the pulmonary artery and you see that there is a opacification of the entire right ventricle. So you have an RVOT conduit which is stenotic, which is regurgitating. There is severe pulmonary regurgitation. There is already a branch pulmonary artery stenosis. It is RPA. I'm not sure whether you will make it out as RPA, but definitely a branch pulmonary artery has been stented and that patient is severe PR. Very good. Now look at 12B and see what is being done in 12B. Conduit stent? Yes. Something more? What is it that was there in the first one and you don't find in it? What is it? Yes, Bhargavi, you got it. It's a transcatheter pulmonary valve. Now, why is it that somebody thought it is transcatheter stent and you said pulmonary valve? What is the one finding based on which you can say that a valve has been implanted, apart from recognizing the appearance? The pulmonary regurgitation has disappeared. You see this? In the first, yes, very good. It's a melody valve and there is no PR. The injection is now well into the pulmonary artery. And where is the PR? You are opacifying only the MPA in branches. Whereas here, I'm going back to 12A now. In 12A, you have injected deep into the PA and the RV is opacified. So there is obvious PR, whereas in 12B, the PR has gone. So this is a melody valve in a conduit, the standard indication. There is an obstruction as well as regurgitation. And in patients being taken up for percutaneous pulmonary valve, it's very common to have a previous stent or something in a branch pulmonary artery. Okay? So here was the answer. RVOT conduit with a long narrow stent with an RPA stent, severe PR. So following melody valve, no PR. Now look at next angiogram. You must tell me the procedure and you must tell me what valves are being used. There is a 13A with one valve and 13B with another valve. The valves are obviously different. You may not have seen one of these, but it's worth knowing. First is melody and second is happy. And Akshara, I am impressed. Have you actually seen Edward sapien being done in India? I didn't know that Edward sapien is actually used in the pulmonary valve in India. Very good. So, good. So you recognized it. Good, Akshara. The 13A, this is the Melody valve. This is the Melody delivery system. The Melody valve is being deployed. It's a longer stent because it's a CP stent which is 34 millimeters long. Whereas here is an Edward sapien valve which is a much shorter in terms of its height. It's a much shorter valve. But it can be implanted in much bigger RV outflows. That is the advantage. So here is a 13A. No, P valve has a very venous P valve has a very different look. So what you have seen is a percutaneous pulmonary valve being deployed. 13A was Melody and 13B was a Edward sapien. It was an XT valve in fact. And the difference between the two, XT Edwards has a shorter height. These are the three heights at which it is available, 14, 17 and 19 with some decimals. It's much shorter compared to Melody valve, which is mounted on a 34 mm CP stent, and that 22 millimeter balloon inflation, which is the largest, it will still be 24 millimeters in height. And you know that Melody cannot be used if the pulmonary valve annulus is more than 22 millimeters in diameter. Edward sapien gives you the options of 23, 26 and 29, widely used in the Middle East and the Western world. Okay, any questions relating to this? Otherwise, next. This 3-day-old baby underwent a cardiac surgery at 3 days, crashed 12 hours later with a saturation of 20%. I am showing you an intervention. Tell me what your diagnosis and tell me what's the intervention. Obviously, we are under stress while performing this. Look at 14A and then look at 14B. Seeing both will give you the diagnosis faster. Neonatal BT shunt. Yes, it's a block BT shunt is the first angiogram. And the second one, there is no stent. It is being recanalized with a coronary balloon and wire. That's all. The reason why you are able to see here we go. It is open with a balloon and a wire, so the pulmonary arteries are now visible. So you had a complete occlusion of a BT shunt due to thrombosis. It has been recanalized with a coronary wire and balloon under very challenging circumstances. Next one, it's a 1-year-old child who was doing well after an open heart surgery with SpO2 of 85%. His SATs now are 70% for the last 1 month. What is the diagnosis and what intervention do you think will help him? Describe the angiogram. Remember, it's a post-op patient, and the patient was cyanotic to begin with, initially improved. Now the SATs have dropped. Yes, it's a bidirectional Glenn with a decompressing vein. Can you describe that bidirectional Glenn a little more? I agree, Bhargavi. It's a Glenn angio and veno-venous collaterals, but you must also tell me something about that bidirectional Glenn. Is it the routine garden variety of bidirectional Glenn, or there's something more than that? It's bilateral BDP. Very good. Yeah, non-pulsatile is a guess because we don't really know whether there is some antegrade flow or not. That's a different matter. But it's not the non-pulsatile part. You should be able to describe it as a bilateral BDG. So it's a bilateral BDG with a decompressing vein. And do you think you can name what the decompressing vein is? As its course is well seen. It looks like the azygous vein. See, it's joining the SVC at about a third of its distance. And as the vein is coming down, it is receiving veins from both sides of the lumbar vertebra. It is the lumbar veins that join together to form the azygous vein. And what will you do for this? If you find such a situation, you would like to occlude that veno-venous collateral, provided you can demonstrate that the PA pressures are okay with balloon occlusion. So if you are occluding that, you should be able to demonstrate with a balloon occlusion first that the PA pressure is not more than 15 millimeters of mercury and that the systemic blood pressure is not dropping. Then only you can do this. Okay? Kavita? Kavita? Angio 16, again you tell me what is the procedure. You should also tell me what is the device that is used. Something that you are very familiar with now. I'm coming to simpler angios towards the end of the presentation. So describe this angiogram, tell me what is the device and tell me what is the route. Okay, quick. I'm on borrowed time. I hope you are seeing this. We are back to pretty routine stuff. I would expect this answer very promptly. Yes, but okay, you should say perimembranous VST closure with an ADO2 device, and it is from the venous side. It's not a retrograde thing. So here an AV loop has been created and the ADO2 device has been deployed from the venous side. So it is an ADO2 device closing a perimembranous VST. Okay. And if you report such an angiogram in an exam, it's very important that each one of these words are used. You should recognize that it's a perimembranous VST closure. You should recognize that it is from the venous axis, because an AV loop has been created and then you would go from the venous axis for this particular angiogram to come. You should also say that it's an ADO2 device. Okay. Now, angio 17, again tell me what's the diagnosis and what's the procedure. Maybe that frozen 17A should help you appreciate what is being done in 17B. Okay? Tell me what is it? Yes? RPA balloon dilatation and stenting. Okay, there you are guessing. What you see? Any other answers? There is balloon for sure. Any other answers? What is happening here? See, I think I should describe this to you. This is the main pulmonary artery. You find that the RPA itself is small, and then as the branches are coming up, almost every lobar artery is stenosed. Can you appreciate that here, at the beginning of this segmental artery, this is stenosed. The upper lobe branch artery is also stenosed. So this is peripheral pulmonary artery stenosis, so the true peripheral pulmonary artery stenosis variety. In that, it is very peripheral. Multiple lobar and segmental arteries are stenosed, and you are seeing a balloon dilatation for that. Actually, it's a cutting balloon. The cutting balloon part you may not be able to appreciate. I'm happy if you say it is cutting balloon, because if the transmission is good, you can see that the margins of the blade in that. That is why initially somebody thought it is a stent. This is a type of situation that you find in conditions like Williams syndrome, and regular balloon dilatation, they do not respond, and it's a cutting balloon that they usually need. And you must have some general idea about cutting balloons. This was a 6 millimeter Boston Scientific cutting balloon. They come in 2 to 8 millimeter sizes. They have 3 to 4 blades within the folds of the balloon. So when you inflate, you do a very slow inflation and deflation. When you inflate, it will deliver a longitudinal tear, and then the balloon would dilate it. For very tough, recalcitrant pulmonary artery stenosis, cutting balloons are used. Basically meant for coronary artery stenosis, but we borrow that use into pulmonary arteries. Okay, so that was peripheral pulmonary artery stenosis being treated with cutting balloon angioplasty. Now in the next one, again the question is, what is the diagnosis, what's the procedure, and if a child is asymptomatic, what would be the indication? This is fairly straightforward. You should be able to tell me this directly. Again, the 18B will give you the diagnosis to 18A more easily. We are still in the pulmonary. Yes, it's a branch pulmonary artery stent. Excellent, Akshara. And you can actually see the stent. You can see the uniformly hypoplastic RPA, LPA. Sorry, pardon me, you are right. So the uniformly hypoplastic LPA, which is being stented here. And remember, if the child is asymptomatic, a demonstrated diminution of pulmonary artery perfusion by more than 20%. It's not a gradient more than 20. No. Why is the gradient not more than 20? That's not the indication. Because if there is an isolated branch pulmonary artery stenosis, the MPA pressure or the RV pressure doesn't go up. The RV pressure remains normal in presence of a unilateral pulmonary artery stenosis if the opposite pulmonary artery is normal. Therefore, you define it not in terms of PA pressure, but in terms of PA perfusion. So a 20% diminution of perfusion of that lung compared to the contralateral lung is the indication. So I moved to the next angio. It's a 43-year-old woman with uncontrolled hypertension. Tell me the diagnosis, what's the procedure, and what are the special considerations in this case? 43-year-old woman. So tell me the diagnosis and tell me the treatment. Yes, first is a coarctation. Yes. We are stenting the coarctation. 43-year-old woman with this coarctation, is there any special consideration for stenting? That's also part of the question. This anatomy of the coarctation in a 43-year-old woman calls for some particular stent. Covered stent, yes, excellent. Not standby. In this, we would, at the age of 43, it's not standby, it's direct. Because the long-standing hypertension and the age above 40 are predictors of vascular injury, not to mention the tortuous stent. So here, we would prefer a covered stent, older patient with a tortuous lesion, there's a greater risk of vascular injury, and that's why we are using a covered stent. Here is the last angiogram. It's a 60-year-old male with atrial fibrillation. There are two procedures shown here. Tell me what they are. Or at least there are two devices shown here. One procedure and two devices. AST device first, of course, I would expect you to say. So tell me, what is the other device? I hope you have noticed it. Here. Yes, LA appendage closure, and which has already been done, and you are seeing AST device closure in such a patient. Remember, it's a 60-year-old patient with atrial fibrillation. So there are indications when you want to close the appendage rather than anticoagulate the patient. And this is one such patient where we have done an LA appendage closure with an AST device closure. Okay? Thank you very much. I think we have had a long session. No. If you have any questions that you want to ask relating to anything, I can give you a short time, but it's late. Thank you. I hope you enjoyed the session and learned something new. LA appendage, it was Watchman. Actually, it was Watchman. In fact, when that was done, there were not 100 devices for LA appendage closure in the market like now. It was Watchman device. Okay? Any other questions? Okay, good night to all of you. Kavita, we'll wind up. Kavita?